Hey, everybody. Welcome back to the Between Sets podcast. My name is Tyler Patterson, of course, and I'm always joined by my co-host, Timothy Walcott.
What's up?
And today we have a special guest on, Matt Angell.
Angel.
The problem is that it has two L's, so it kind of throws you off.
Everybody, yeah.
Yeah. So you're like, what do I say here?
Angell.
I'm going to let Matt intro himself, but Matt is a massage therapist, and that's how we met. And I'll let you take it from there, Matt. Tell us about yourself.
Thanks, Tyler. My name's Matt Angell, two L's. You have to pronounce the second L next time for me, okay?
You got it.
Yeah, so I'm a massage therapist. I work out of a couple clinics, one here in Cambridge, Ontario, and another in Guelph, Ontario. I've been an RMT for coming up on 4 years, so I guess you could say I'm still relatively new to the profession. And it just so happens that Tyler Patterson was one of my mentors. I got to do some placement hours under him, and that's how we kind of got to know each other. And I was lucky enough that he invited me on the podcast here today.
Nice. How was being my mentee, Matt? Let everyone know.
You know, it wasn't the worst because, you know, I got to spend most of my days in the gym there. I think we spent more time working out than we did actually treating patients. But
We definitely did. Yeah.
you know, it worked out nicely because we're very like-minded individuals, so I can't complain.
Nice. Was there anything in school? This is actually a good first question, I guess. Was there anything in school that you learned that maybe I contradicted when you were like menteeing under me?
You know, it's tough to remember, you know, what happened, you know, 4 to 5 years ago now, but, you know, I'm sure there was at some point. I mean, this is one of those professions where there's a lot of people bashing heads, right? And if you're not constantly changing your idea on things, you're not adapting as a therapist. So there's nothing off the top of my head that really sticks out, but I'm sure there was something.
Yeah. Well, actually, let's bring the question even farther. Was there anything you learned in school that you were like, I don't know if that's right? Were you skeptical about some stuff in school that?
Yeah, probably. Again, it's a question where I'm really unsure. I think when you're at school, you know, you view the teachers and the schooling itself as the end game. There, like they know it all. So it's pretty easy to buy in under that given scenario. I think it was more so after school where I started to get information from other sources that really contradicted what I learned at school more than anything. So it was probably mostly after school that I started to notice maybe things aren't quite as black and white. It's a little bit more gray than we once thought.
Do you remember the first thing that kind of sparked that thought there?
I'm going to say that the biomedical model, I think that was a very large prevalence in schooling for me personally. I'm sure there was some of the BioPsychoSocial model implemented there, but you know, given our hands-on modalities, I think it was mostly biomedical. And when I got out of school there, you started kind of learning about different models of pain, learning from different practitioners, you know, especially regarding chronic patients, things like that, you know, it's not all biomedical. You don't have to have, or there's a larger explanation for things, right? For people's experiences, whether it's pain or function, things like that.
Definitely.
Was it, do you think it was being like your exposure to chronic pain patients that was a large contributor to opening your mind to psychosocial factors being involved with pain?
I think so, just because it's the chronic patients you see that typically show those signs of what you'd call like the flag systems, right? So the psychological, sociological pieces, because especially with chronic pain patients, they've had the time for the biomedical to heal. So think muscle strains, non-specific back pain, things like that, where you expect things to heal after a certain time. And even if you want to get into the obvious one is if you think of phantom limb pain, right? That's obviously not a biomedical reasoning to have pain in something that doesn't exist anymore.
Mm-hmm.
So it's really probably, you're right, the chronic pain patients that really opened my eyes towards it. Yeah.
That's cool. What were you going to ask, Ty? I interrupted you.
Yeah. I don't really remember, but no, I couldn't agree. Actually, this is a good kind of segue into that and the whole chronic pain thought. Matt, you recently posted a question in one of the groups that we're involved in on Facebook, and you were talking about some disorders that we commonly say as they're chronic issues, but technically you wouldn't actually call it chronic. So chronic would mean, the definition of that would be anything that lasts, like a pain that lasts longer than 6 months, 3 to 6 months typically. And then the disorders you put up were typical ones that were typically longer, right? So would you call those chronic? And I thought it was just a cool question. And you had a few, I'm sure you had a few different answers. I didn't fully go through it. So do you want to, what sparked that question in your head, Matt?
Well, I just happened to be reading a book, and that scenario came up, and I wanted to get other people's thoughts on it. So the book is written by a physiotherapist who has since passed away. His name was Lewis Gifford. And he poses the question of, we typically define chronic as greater than 3 months. I've seen some different numbers. You're right, 3 to 6, but I think 3 is a pretty common one. And I think there's implications with the word chronic, right? Whether it's, so when I hear chronic, I kind of think that the pain is coming from a different, is happening for a different reason. So you could think nociceptive versus central sensitization, right? When I hear chronic, I do think central sensitization. So I think it'd be better to maybe define your pain based on those descriptors versus chronic for one. I think it's a little bit more accurate that way. But I brought up some things like, I think I talked about some tendinopathies or frozen shoulders, or these diagnoses that typically last longer than 3 months, but we don't call them chronic. So I was just kind of curious if chronic was the right term to use. I know in this profession, words matter. And if you look back a couple posts from there, I talked about iatrogenics, which is, we kind of catastrophize the patient themselves and they become sick because of it. So if we use the term chronic, they have negative connotations with that. So I think that I just wanted to visit the word chronic and see what people's different definitions were, and if there was a better way to utilize that word itself.
Definitely. I think therein lies the problem. A lot of massage therapists, and I'm assuming you would agree, Matt, we're very hands-on. A lot of therapists are very hands-on. I don't think it's a shock to anybody that I'm very educational based. I want people to understand their own problems. So to be able to explain to somebody the prognosis, like the amount of time they should expect this problem to kind of be there, and give them the progression of their symptoms, or regression of their pain, hopefully. So over time, you should expect it to be this long, to set them up for the thought that, like, okay, it could happen. It could be happening for this long. So what do we do from here? Right. Let's say you have frozen shoulder, which typically lasts obviously there's a spectrum, but like from 1 year to 3 years, it can last a long time. So what do you do for a person that has frozen shoulder? Do you say, oh, it's chronic, see you later? Like, or do you, come in every week for the next 3 years, we're going to work on you. Right. There's no cure for it. So I think I do agree with that. Of course, that calling something chronic can be bad for someone's psychosocial, thoughts, and kind of biology, because then they'll be stressed all the time about their frozen shoulder. Right. So it is about patient education and being able to tell someone, rather than just being like that lazy, it's chronic, see ya. Right. Like I feel like some doctors do. I'm not trying to put everybody under the bus, but they just go, it's just the way it is. Like, take a Tylenol. And they're like, well, they came in to see you and all you did was do that. I actually had a patient recently, obviously before this whole COVID thing, and we were talking about how they waited 18 months to go see a surgeon for their knee, and the surgeon came in, didn't even look at them, and was like, well, I don't really know that we can do anything. See ya. Didn't even look at them, didn't ask them any questions, looked at the CAT scan or MRI or whatever they had, and just left. And my patient was waiting for 18 months to see this surgeon, and has less answers than they had before, and feels way worse about their own problem. And I was like, oh,
no
so
kidding.
I think it's funny because when you pose the question on Facebook, my brain was like, this is kind of semantics from a massage therapist standpoint. So if I said that to another massage therapist, I think trying to, argue about the semantics of wording is, I don't know if it's necessary between us, but then it makes me think it is necessary, because if massage therapists are saying chronic to all their patients, it makes sense. But so it was a cool question. It got me thinking about a lot of stuff.
Yeah, I was very much in the semantics camp as well. I mean, this isn't the first time people have talked about wording and its effect, but I've since definitely changed my thought on that. I think we do need to be pretty specific, especially for our patients who have no idea what's going on. We really have to break it down for them.
Definitely.
Well, and like the thing about chronic too, just like thinking about it, basically what you guys are describing is like, and what you kind of just touched on was you would use chronic as a practitioner, you would use chronic based on how long the condition's been a problem, right? How long it's been presenting with symptoms.
Yeah.
Typically.
Something and plus or minus whatever else. And then the problem is that the individual then sees a future issue with that, right? They don't really care. I mean, they do care to a degree how long it's been lasting, but they hear chronic, and the problem therein lies they are worried now that this will last forever. It's not just like, okay, it's been 3 months, this is now chronic. It's like, why would they be afraid of that now? You're only in the present. It's still lasted 3 months, or it hasn't, and it has. What is the problem here when you use the term chronic? Well, now you've made them fear for the future, I think is the problem.
That's my interpretation as well.
Okay. Yeah. That was my thoughts of like how that changes, and also how the practitioner and the patient can see it differently. You know, the practitioner's just like, oh, this is just what you would call it. Of course, not a big deal. We might even fix it tomorrow. But the patient hears chronic and may think, you know, oh, that means I have this forever. My dad has chronic low back pain, and he's always been, you know, walking weird for as long as I've known him.
Mm-hmm.
Yeah. So, but anyways,
Matt, how does that change your approach when you have a patient in front of you? Do you tell them I guess the scientific words, or do you like specifically just do layman's? Like, how do you approach that?
You know, I try my best to gauge their vocabulary as well, right? So, you know, and I don't know if it changes too much from a back pain perspective. I try and educate them on the whole pathology itself. I will sometimes say chronic because people understand what that word means. Persistent is something I think I'm switching over to a little bit more. I know if you look at the Lancet journal and their low back pain, they don't use the term chronic after 12 weeks. They use the term persistent. So I think that's kind of a good way to go about it as well. I do try and break everything down into layman's terms. It's, you know, it's like me taking my car to the mechanic. They're going to start talking about all this stuff that's going on in my car, and I have literally no idea. I can just about fuel it up and put some windshield washer fluid in, but other than that, I don't know what anything is in a car. So if they kind of bring things into layman's terms for me, I'm very much appreciative. I understand what's going on, and you know, these big words could be catastrophizing in and of themselves. So I try and break it down so people understand, because education, you just mentioned it, is arguably the most important thing that we give to a client within our treatment time.
Definitely. What are some issues that you've had trying to obviously go from, you know, Tim and I have talked about this a million times, but going from the biomedical model into the biopsychosocial approach, what were the troubles there when actually trying to converse with a patient? Like, how have you grown in the past, however long you've been kind of operating underneath the biopsychosocial pain model?
There's probably a few that kind of jump to my mind. The first kind of, you know, limiting factor for transitioning was my understanding of the biopsychosocial model.
Sure.
You know, how it affects everyone day to day. So our thoughts, our beliefs, things like that. I'm someone who likes to kind of understand something at the base level there. Where I want to know everything what's going on. I'm definitely not a neuroscience guy by any means. So the fact that I don't understand it myself completely makes it difficult for me to relay that onto patients. Now there are some obvious things that I kind of somewhat understand regarding, you know, beliefs and things like that, appraisals that we just kind of talked about. But, you know, getting that from my own words and my understandings to someone who might not see things the same way I see them, and I have to kind of explain it a different way, that's also troublesome. I think the last thing that really stands out for me is the biomedical model is so well understood by everyone, right? They all think, if you were to ask anyone, they would all think Cartesian model, where if my hand hurts, there must be something wrong with my hand, right? They don't understand that things could become sensitized from the psychological or the sociological piece as well. And trying to change someone's beliefs is one of the hardest things you'll ever do. Challenging someone's belief systems is incredibly hard. And we kind of talked about it before the podcast, how you can't be very aggressive with changing someone's beliefs, right? It's something you have to do over time, and hopefully provide little examples that really kind of set the light bulb off in their head.
Yeah, fair enough. Well, even I said it on I think it was on the Stu McGill podcast. And I said, I pretty much start every single, new interaction with a patient with, what can I do for you? And then I just don't talk for the next however long they're talking for, until there's a complete pause and they were waiting for me to talk. Right.
Mhm.
Because they'll tell you exactly what they think they need. And then you can approach it like, okay, I think they would like this approach, or they wouldn't like this approach, or how to tell them what is going on, rather than I found patients would come in and I would ask them what was wrong, and I would kind of interrupt them and be like, they would tell me they have degenerative disc disease, and I would immediately be like, it's not a thing. And I would just kind of braid them with these things that it isn't. And it wasn't a good way to start the conversation, because now they think I'm just going to tell them that everything they think is wrong or know is wrong. So I think it's a very important thing. And I think you are in the same boat as me, where I'm really trying to make other massage therapists understand. And it's that words matter, and you need to start treating people differently. We've changed. We've been doing it like this forever. Doesn't mean we should keep doing it that way.
Totally.
But like you said, it's really hard to change someone's mind. So how do we approach that? And I think it's nice that you ask questions, and it's kind of a question to get people thinking, rather than, I think this, I think you're wrong. What do you guys think? Rather than, here, what do you guys think about this? And there's a lot of nice conversation, and hopefully we can, decrease the blowback effect, and not have people just get mad at us that we're trying to change their mind on something.
For sure. That's the best way to progress the profession itself, right? Challenging someone respectfully with a question versus, you're wrong for thinking this, right?
Definitely.
Matt,
Yeah.
do you listen to You Are Not So Smart podcast?
I haven't.
Oh, okay. They talk a lot about that, as far as different cognitive biases and just logical fallacies, and as far as how all those fit into belief change and communicating with other people, as far as disagreements, debates, arguments, and just challenging people's belief systems. It's kind of cool.
I'm looking at it right now, so I remember to download it.
Yeah. You Are Not So Smart. They have their episodes are pretty cool. They're really well produced, and they explain a lot of these concepts really, really well. And I found they're useful for me as a personal trainer and a nutrition coach, as far as when I'm trying to challenge some of my clients' beliefs, or try and change their behaviors. It's been a really good learning resource for me as far as how to do that. Because even what Ty was talking about there, I have tons, we've talked about this countless times. I have tons of examples of that where you just look back and you just cringe with how you dealt with a certain conversation with a client, where you just didn't handle it as you handled it as best you could at that time, for sure. Right. To give us credit, I think, right. Everybody, it's a learning experience, but you look back with what you know now and you go, I can't believe I went at it like that, but yeah, I find that podcast has been super helpful. What I was going to ask you actually about, kind of along the same lines, is when you started understanding more about pain, and that maybe the biomedical model, the conventional model that everything has a physical or biological cause. When you were learning more about the psychosocial aspects of pain, did you find it challenging to reconcile that with your field of massage therapy, which is a form of manual therapy, which is obviously, there's a large biological aspect to that.
Mm-hmm. Yeah. I think it probably was very challenging. I know, in the clinic firsthand, people probably get a little bit irritated with the fact that you kind of probe so much for those flags, addressing those flags. I think massage therapy, especially, it's one of those treatments you get done to you versus you take part in, right? And taking part in it and having a conversation about pain and some of the things that could be aggravating factors for people from that psychosocial perspective is always not sometimes well received. I think it's not necessarily the norm until more recently that we've addressed this. And that's not just in massage therapy, that probably goes for other clinicians too, whether you're a chiropractor or a physiotherapist or someone of the likes. So there's probably a little bit of not blowback, but a little bit of abrasiveness trying to get it to implement it into the clinic there.
Yeah. Did you what about personally, do you have any and maybe you don't, but just any examples? I know that just from Tyler's perspective, and he can probably kind of elucidate more on this, but it was very interesting transition watching Tyler go through the struggle of being like, I'm learning all these things. Now, are all of these things that I'm learning, are they in direct opposition to what I do? Am I now obsolete, or can I figure out a way to reconcile this with what I do? Or is that just confirming my own bias and trying to keep myself alive? Like it was kind of, yeah, it was definitely a challenge for Ty, for sure. I think watching that transition go down.
Yeah, I think if it's not a challenge for you, you're probably not doing it correctly.
Yeah, I would agree.
I mean, no transition should ever be that smooth, really.
Yeah.
Yeah. No, it's very true. Even when I first started, I think I've talked about this before, so I apologize to anyone that's hearing this for the 10th time. But the pendulum kind of swung all the way to the other side, meaning I used to think I could fix everything with my hands, and then going to, I can't fix anything with my hands, and this is all bullshit.
Mm-hmm.
So obviously I've came back down to the middle, and through conversations, even with, someone like Stu McGill, where he really puts in perspective, like why I kind of took the bio out of biopsychosocial. I was just doing psychosocial, so that didn't actually help. So again, understanding, if you can tell someone about the biology, back to what we were talking about before with the chronic pain, explaining chronic pain to a patient. If you can explain the biology of their problem, the prognosis of their issue, right? They're going to feel better about a lot of stuff. So that kind of helps the psycho right there. So yeah, you address the bio, and, I still use manual therapy techniques if I can tell that if I don't do that, they're not going to feel any better at all. And they're just not going to come back. And the name of the game is getting someone back, because it's going to take a while for them to understand what their pain is and how to go forward, right? I can't do it in an hour. So if I just don't get them back, I don't want them to go, that dude just talked to me and I just feel way worse now, right? So obviously understanding where they're coming from. Yeah, it was definitely hard to go from the biomedical into the biopsychosocial. So I think it is really important to address the biological. That kind of leads me into the next question about how does, actually, with this whole COVID thing going on right now, of course, I think the best argument right now to other massage therapists that, believe that the person has to be in front of them to make a difference, and I have to put my hands on you. How are all your patients faring right now? Are they like, oh my God, I'm going to die. This is horrible. I need to come see you. This is ridiculous. I was telling Tim yesterday, I've actually had a lot of patients messaging me, or I'd, obviously call them to cancel because of this COVID thing happening. And I go, how are you feeling? They go, well, I'm hurting, but like, I feel better. Like, I feel like I can handle it myself. And it's the best feeling ever for me. And I think it's an important question to ask, like, in a time like this, when someone can't see you, are they reliant on you, or do you have an alliance? Have you taught them how to help themselves? Right. So it's funny whenever I hear someone giving the biopsychosocial model a hard time, and I'm like, you really don't understand what it does for your patients. I truly think you don't understand. And again, which is very hard for me to go, I think you're hurting your patients, but I want to be able to explain to you why I think you're doing that without you going, well, I make so much money and all this stuff. And it's definitely a hard approach. So my question in there, Matt, I kind of lost my train of thought because I started venting a little bit.
No, it's all good.
Oh God.
Are you going to talk about telehealth just in general?
Oh yeah. We were going to talk about telehealth. So you actually recently posted about, how, like, is the CMTO, which is like mine and Matt's regulatory body, are they going to start appreciating the fact that, I'll let you take it from here, Matt, but are they going to understand the value of telehealth at all? So what kind of got you sparked in that, Matt?
That's a good question. Are they going to realize the value in it? I kind of just posted quickly because, we're probably the only healthcare practitioners that aren't allowed to use it. Telehealth, aren't we?
Pretty much, I think.
I think like everyone else is allowed to use it. We're pretty limited as far as our scope there, it seems like. So I think we do provide value via telehealth. So I think a lot of people see us for our hands-on, right? And that's fantastic. I think that's something that absolutely sets us apart from other professions, right? I think people value the hands-on aspect of things. However, we're not, it's very reductionist to look at us as that's all we are, right? I think there's a lot of things outside of our hands-on techniques that provide value to our patients, whether that's, positive affirmations, reassurance, education, treatment plans, time, collaboration. That all develops that therapeutic alliance that is really the underlying mechanism for a lot of the stuff we do. And I think that we should be able to use telehealth for that reason. Now, I understand that the hands-on is a large piece that's handed down to us that gives us our scope. But I mean, existential circumstances call for other means, right? I think, to be honest, our patients are worse off by not having access to us right now than what our quote unquote liabilities would be via telecommunications.
That's right.
Now that's something that, I didn't know how to go about ever figuring out how to get that implemented from the college and into our scope of practice. So I kind of posted in that Facebook group today, because there's people a lot smarter than me in that group. So I wanted to kind of just get a conversation going to see what people thought about it.
Definitely. Well, I mean, it's going to take 30 years before they actually get to it, of course. No, it's an important conversation to have, but I think they would just go, "You're a massage therapist, massage people." So it would definitely be a hard thing.
That's pigeonholing. We provide so much more than our hands-on techniques, right?
Definitely. Yeah.
Do you actually? I have a question for both of you on that note. Do you think I'd actually never considered this before, but with the acknowledgement and I don't know if implementation is the right word, but let's just say the acknowledgement of a all-encompassing BPS model approach to pain as massage therapists, do you think that actually, in general, helps? I'm trying to think of a better word for it, but helps your industry because, maybe stereotypically in the past, massage therapists just being seen as like Tyler's used the term oil pusher before and things like that, right? Where it's like it seems very simplified and obviously over reduced, but now it actually shows that there is so many more factors and capacities within your potential and the way you can affect your patient. You know what I mean? Which we're all aware of, I'm sure. But do you think, like, say in 10 years, 20 years, 30 years from now, your industry will actually be totally different in a sense?
I hope so.
In a positive way?
If you don't adapt, you die, right?
Mm-hmm.
Yeah.
If we don't acknowledge the biopsychosocial, if we don't acknowledge the hands-off soft tissue treatment, such as therapeutic exercise, things like that, we'll become irrelevant, because we're learning that healthcare is so much more than as Tyler said. I like it, being an oil pusher. I never heard that one before. I do think manual therapy has a place, but it's not the be-all end-all of healthcare.
Mm-hmm.
So I think we need to adapt to stay relevant.
Mm-hmm.
I know a lot of it in the past is with the end of 2019, mid 2019, Tyler, where there were some insurance companies kind of questioning what we do, right? And to be honest, when it comes to a time like this where it seems like all we're good for is our hands, I almost want to side with them, right? I think we are so much more valuable, though.
Definitely. Well, there's a few things to say. Well, to acknowledge that right now, a bunch of insurance companies were thinking like, why would we give massage benefits? All you do is push oil. Like, they didn't actually see the value in what we give. And actually, as an aside, I actually believe that massage therapists shouldn't. This is gonna be a weird one. Relaxation massage. So if a person doesn't have any kind of problem other than feel kind of stressed, I just want someone to push oil on me, I don't think that should be. No, I don't really know how to approach this. Should that be, first of all, part of our standards of practice, right? Is just like doing a relaxation massage, because there's really no therapeutic benefit to that, I guess. But so I can see where insurance companies are kind of coming from, right? But if this helps someone, again, people are going to go see someone that they want to see. Chiropractor, massage therapist, physiotherapist, and there's a huge dose of placebo in every single one of those modalities. Mm-hmm. So I guess it's kind of like picking your poison. Like, it doesn't matter which one you enjoy. So I think insurance companies should give this whatever money that person wants. If they just want to see a massage therapist, they should give that an allotment of however many dollars to just massage therapy. Like people should pick, rather than wasting a bunch of money on like, oh, I got $500 for everybody, but I don't want to see a naturopath or a chiropractor or a physiotherapist. And now they just have to split their time between those people. But yeah, I was almost just going to say that I don't think massage therapists should be able to, or so people should use their benefits for just relaxation massages. That should just be left to like spa people, I guess. But I don't know, that's kind of a dicey subject.
I know what you're saying. You could make arguments either way. And I think you're already kind of going through that in your own head, right? Yeah. You could make arguments on both sides. I think, that relaxation massages are still therapeutic in some way, especially with the understanding of psychosocial factors going into a massage.
Yeah. Definitely. I mean, I'm not someone who treats that way, but I definitely see value in it.
Mm-hmm. Oh, I forget what my second point was going to be.
But I know what you're saying, Ty. Like you're basically maybe you're not taking a hard stance on it, which is fair, but you're at least challenging it and being like, well, maybe we should question it, which makes sense. I think that's fair.
Definitely.
Yeah.
What were we talking about before? I'm trying to figure out what my second one was. I was really excited about it, but I don't remember what my second point was going to be. Yeah, it's, oh man. Well, carry on, boys, because I can't.
That's all good. That's all good.
Tim, if you have any questions?
I did have a while we're on all my questions are all around the BPS stuff, just because I knew that whenever we got Matt on the podcast, we'd be able to nerd out about this stuff. And you can keep going forever, I know. So, but my question to you, Matt, is very simply, do biomechanics matter? And if so, when and how? I know it's very general, but go down that rabbit hole.
No, it's not that general, actually. I have to say, of course they matter. I think if you neglect them altogether, you'll probably have some poor outcomes. There's some instances you have to consider. And, I've always kind of looked to Greg Lehman for this one. He has a great course, Reconciling Pain and Biomechanics. So in that course, I know he's talked about, high load activities and injury prevention. So there's probably some provocative positions you'd want to avoid. Things, a very hot topic one, especially with the prevalence of ACL injuries, excessive valgus in the knee kind of thing. Mm-hmm. Not saying don't do that, but if you're ever in a high force position, a very common one would be, I know a common mechanism for women is soccer players, because that pivot when they turn off their foot brings them into a high force valgus position with less than 25-30 degrees of knee flexion, and that puts a lot of strain on some of the tissues in the knee, especially the ACL, and you do see injuries there. I don't think it's outrageous to say that we should probably not avoid. We could definitely train for it, but to be put under that high stress load all the time, we do increase likelihood of an injury.
Right.
I think performance is another one we have to consider biomechanics. If you look at any top level athletes, if you were to say, what does good posture look like? What does good performance look like? You ever seen Rory McIlroy swing a golf club? It's the most beautiful thing in the world, right? To say biomechanics don't matter, the guy hits it the furthest on tour of anybody, right? So to say they don't matter is kind of silly there. If you want to have good performance, you should, develop good biomechanical positions. It just makes it more efficient. And then another one I think is a good time to address biomechanics is pain. And that's not to say that a biomechanical position is bad, right? But if I bend over to tie my shoe and I have low back pain when I go into flexion, it's not outrageous to say, why don't you kind of bend down with more of a neutral spine, or bring the foot up to you where you can keep the spine a little bit more neutral, because it doesn't put you in that provocative position just for now, while things start to settle down and the tissues desensitize. That's a good time to change biomechanics. I think the negative side of the biomechanical piece is the narrative that some clinicians give. So going back to my bending over example, is it bad that I flex the spine? Not necessarily, but some people will say spine flexion is bad, when that's not the case. It's just very sensitive at this moment in time, right? So we avoid it for now, and when you're feeling better, you'll go back to bending over and tying your shoe.
Yeah, definitely.
So those are typically three times when I think they really matter.
That was good. Yeah, I think that makes a lot of sense.
Yeah. Imagine, Matt, you were just like, biomechanics don't matter, next.
Right.
just
I'm the
didn't
most
care.
boring
Like,
podcast host.
yeah.
You already got me way too close to the Stu McGill podcast, so.
I know. Yeah, seriously. Guys, I remember what I was going to say before, because Tim, your original question was talking about, do you think our profession is it going to keep increasing? And Matt, you alluded to like, you hope it does, basically. I have a little bit of firsthand knowledge / experience in this, that I'm part of the program advisory committee at Humber. So we're trying to make the massage therapy program better, right? So we meet every 2 months or kind of once a quarter to talk about, the emerging trends and current evidence and that sort of stuff. And how can we shape the program in a way that people like the students learn kind of the new stuff that's coming out. So rather than continue to do the old stuff, breaking down adhesions with your fingers, doing this with friction, that's not a thing. So it's actually out of the curriculum. That's stuff like that we are getting better. They actually have, when I was in school, we had one therapeutic exercise class. Now they have 2. So whenever I go to these meetings, every single time I go, I'm like, I want to go back into school, because they're finally teaching in a way that, like, first of all, confirms my bias, which is always fantastic, but actually is like operating underneath the current evidence, like, understanding the psychosocial. So understanding how biology plays into the psychosocial. So like you just said, Matt, like, to say biomechanics doesn't matter is hilarious. That's obviously not. Does it matter as much as people think? Maybe not. It's probably somewhere in the middle, as with most things, right? So again, with your beautiful examples of like, spinal flexion is not bad at all, but if it's hurting, that's bad for you, right? Like, don't hurt. If you can do something that doesn't hurt, accomplish the same task in a way that doesn't hurt, that's amazing. So biomechanics matter in that perspective. So it's, I think it'd be horribly reductionist to say that biomechanics don't matter, for sure. So I'm glad that you didn't say that. Otherwise, we would have had a controversial podcast, because I would have yelled at you.
That would have been awesome. We want the drama, baby.
We want the drama. Yeah. I have a question for you, Tyler. And that point you just talked about, how you're kind of quote unquote revamping that massage therapy program at Humber there.
Sure.
How difficult is it for you to implement your ideas, given the fact that the point of schooling is to prepare you for your OSCEs and MCQ with the CMTO? Yeah. Obviously, there's probably a lot of things you just want to throw out, such as friction massage or things like that, but you can't, because that's still a standard for the CMTO.
Yeah. So yeah, I think I just said that it's not in the curriculum. I apologize. I don't think that was actually, that was not actually right.
Okay.
I was just thinking that, like, it is a tricky one for sure. So I was actually going to allude to that already. So great question. You have to pass the tests to become a massage therapist. So you have to learn these things. When I was in school, I won't say the teacher, I won't put them on blast, but they would teach us something, and then they would take a few of us into the corner and just go, it's not really how it is. Like, here's the new current evidence. I just can't. He said, learn this, but it's not really right, So It is super hard. So that's actually why everything is going to be so slow. So until you get everyone together, every school and the CMTO, to be like, this is the current evidence. This shouldn't be on the tests. So I don't think the kids should have to learn it. The students should have to learn it.
Mm.
Right. Obviously it takes a long time. So that's why implementing things are relatively slow.
Yeah.
Right. I've been part of this committee since I graduated, actually, because they wanted a fresh perspective. So I've been in it for 5 years. And that's how slow it's been to make the program a little bit different. And so that's pretty much it. We're pretty much going to have to get the CMTO to change their mind on stuff.
That's it. It's got to be top down, eh?
Yeah. So it's unfortunate for sure. Because even when I go, the teachers there and the program coordinator there will ask me to come in and speak to the students and just have a panel discussion, and they ask questions. And I'm like, I just kind of have to bite my tongue for a lot of things, because I go, well, I'm going to directly contradict what you guys are learning, and it won't help, because you might not pass the test, because you'll look at the question and be like, Tyler said this was wrong, and then the question was actually, no, it was right. So yeah, it
makes it tough.
Yeah, it's good that there's clinicians like yourself, making rumblings down lower in the chain, right? Eventually that'll get the CMTO's attention.
Yeah. Well, like you just said, Matt, there's the group that you actually invited me to today, there's a lot smarter people in it than you and I, and hopefully they can make a difference. And they've been in the profession for a long time, and they have, their thoughts are so articulate and so well put that maybe it'll get people thinking like, that's a good plan. But the CMTO is a business first and foremost. So it's kind of hard to try to change their mind. So yeah, great question, Matt. I obviously don't have the answer at all. But
I don't
think
either,
it's trying to get them to understand, like what I was saying before, that what we say matters and hurts our patients. So you're trying to progress the profession, but you're still letting people explain to patients these kind of like things that we know to be wrong now. But you would have to convince someone higher up in the CMTO has to go, that's right. Like, and go, we're going to change this all right now. But that's going to be, it'll be a long time if that is going to happen. So I think just treating patients in a way that you think is helping is pretty much the best thing you can do. Because I genuinely believe that all massage therapists, even if I think your approach is not great, I certainly hope you're actually trying to help your patients. And I'm assuming you are helping your patients if you've stayed in employed.
Mm-hmm.
That's pretty much it.
There's more than one way to skin a cat, right?
Exactly.
Matt, on that point, question for you. Do you think that social media then would be a powerful tool at this time, just because so many people are on it, especially in the health fitness world and pain rehab world now? Just so many people on Instagram and Facebook. I think that's a way to change things and get those rumblings going.
For sure can be a way. Welcome to social media where, there's a lot of snake oil people as well, right? It's tough to get kind of know what reputable sources are now and things like that. So I think there's a lot of positive in social media where you can get a lot of the new information out to the public, to other therapists very, very quickly.
Yeah.
But again, there's that negative side too, where you do have, the snake oil people trying to push their product on you.
I guess it depends on what circles you find yourself in, eh?
Totally. And especially someone who is uneducated in it, right? They don't know any better.
Yeah. What are your thoughts on, do you think it's harmful for, the greater good and changing the industry for the positive, as far as some of these characters on social media using a lot of like vulgar language or calling people out? There's a bit of that, not a ton, but there's a bit of that. What are your thoughts on that?
I respect people who like to be themselves, right? Because you're never going to please everyone.
Sure.
Right?
Yeah.
I remember it was Jordan Syatt's kind of brought this up recently. There's a lot of people who don't really respect him because he cusses in his videos and things like that.
Mm-hmm.
But he's like, people are going to hate me either way, and so I'm just going to do things the way I want to do them, right?
I agree with that. Yeah.
And I can think of some other therapists who are, vulgar and very abrasive.
Mm-hmm.
Do I necessarily think it's the proper way to go about things? Probably not the way I would do it, right?
Mm-hmm.
But if they feel like that's working for them, then so be it.
I think that's a good answer. Yeah, because I do agree. It's tricky because I do fully agree with people being themselves and letting themselves kind of shine through with their message, especially if the content's quality and it's evidence based is one thing, where it's like, okay, great, you're actually saying things I agree with and that the current evidence agrees with, but your delivery is kind of aggressive, sometimes
do you have someone in mind when you're saying this?
Yes.
I know exactly.
I know exactly what you're talking about. Yeah, for sure.
Yeah.
I mean, you can be abrasive, but are you going to get through to people that way? Right. Challenging them very aggressively.
Because here's the thing, right?
Is the best thing in my opinion.
I agree. And I think it's an interesting conversation because the person I'm thinking of in particular, they also seem to have the most issues. Coincidence?
Or they're just more vocal about the issues versus other people who aren't. I don't know.
Maybe. Yeah. I like what I think they attract it is what I think.
For sure.
I think which, if you're going to, I support the right as well. It's like, if you want to put that out there, then just get ready for the consequences. But it's kind of like, don't be surprised if you do get that kind of response because you're putting it out there in that way,
For sure.
But
no, I think it's funny because I would bet a large sum of money that we all have the same guy in our head right now.
Yeah. How do you know it's not a female, Matt?
It's
females are
2020. Does anyone know?
Yeah, yeah, I don't
females
know.
are wonderful and really nice. Okay, Tim,
Yeah.
they would
Yeah,
never
all
be
of them.
they would never be the face of controversy.
Let's pivot, boys. Let's talk about stretching, because this is where we can all probably agree. And now the audience totally tunes out because there's going to be well, actually, maybe there will be some disagreement here. But just based on what I've seen from Matt's postings, I think at least in the foundations, we all kind of agree on that type of stuff. And me and Tyler have talked about it a ton, especially because we've had an interesting kind of history of feedback as we've put our thoughts and perspectives on stretching out there. Yeah, I'm familiar with kind of your thoughts on that, Matt, as far as like, do you recommend stretching? What kind of stretching? Is stretching completely useless? Is it useful in some contexts? Outside of performance, let's talk Gen Pop strictly.
Yep. Well, yeah, I know one of the questions Tyler asked me to have prepared is, if I disagree with you guys about anything. So I had to do some dig deep in on some of the content I pushed out about, you're looking for the controversy, but guys, I think the reason, I follow you guys and whatnot is because we're so like-minded. So I don't know if there's anything you guys have posted before that really kind of had me questioning it, but yeah, so I think you guys might be alluding to, I kind of did probably a 6 or 7 part series on, it's mainly on static stretching for the most part, because it seems like that is the majority of RMT's remedial exercise, which is very disappointing to see. But that's probably another conversation for another day. But as far as stretching goes, I'd kind of gotten into a conversation in one of the clinics I worked at with a couple of the physios, and I always see in their notes that it's often prescribed and things like that. And I didn't really see too much benefit when it came to stretching. I think if you kind of look at the value of time that you have to spend doing it and whatnot, what kind of return on investment are you getting from it? And I thought it was kind of a low return. So I kind of wanted to deep dive into, why we use it, the mechanisms, its relation to injury or performance or posture, things like that. So I kind of did this 6 or 7 part series on my Instagram there, addressing some of those pieces.
Do you want kind of going regarding those posts? Do you want to tell the audience right now, people who maybe don't really, as far as what stretching is to them, that means like holding your foot up to your butt before you go for a run, or doing some type of weird hamstring stretch. Do you want to tell them kind of, all three of us kind of understand, I think, our general consensus on what we believe, but Matt, do you want to tell the audience what we believe, or at least you believe stretching to be doing, like what the mechanisms are that you kind of alluded to there? Yeah,
for sure. So I think there's a few mechanisms to stretching. I think there's the some neural changes. So for example, a stretch tolerance, right? So if you just kind of repetitively do a hamstring stretch or whatever, you notice that over time you start to go further. A lot of people believe that it's your muscle physically elongating, which might actually turn out to be true. But there's also a neural change there. It's your body just adapting to the stress of it. So you can actually go further over time, even though there is no change in the stress strain curve. So there's no more strain to the tissue versus before. It's just you've adapted to that the feedback mechanism there, which is the stretch tolerance. There are some biomechanical changes, which it actually turns out it was kind of a very hotly debated piece for a long time, which means you can actually go further, so more strain, but less stress. So you don't have to push as hard to go as far. But that seems to be musculature only, so not necessarily the tendon or other non-contractile tissues like joint capsules or ligaments, things like that. So there's 2 mechanisms there, the biomechanical and the neural. So kind of feeding off what I was just saying there is when it comes to non-contractile tissues like tendon, ligaments, joint capsules, it only senses tension. So it's almost as if you're exercising when you do it. And what happens to tissues when they undergo tension? They stiffen up, right? It's kind of like people associate weight training with, right? Weight training is basically just a stretch for your muscles. Essentially, it's tension. It's the exact same thing.
Yep.
So the muscles actually adapt and actually could get longer, meaning more sarcomeres, and then the neural changes regarding them. But when it comes to non-contractile tissue, it seems that it just stiffens. Hence why I think there is some value as far as injury reduction. As far as injury reduction, it's not shown to decrease injuries. However, if you narrow it down to specific injuries, so injuries at the tendon junction, there is some literature that does suggest a reduction in tendon injuries. So it won't necessarily help the muscle, but can help the tendon itself.
Yeah, I can't tell you how many, how many clients I've had, personal training clients, where they undergo some type of muscle strain, some type of mild muscle strain somewhere, whatever, right? Something they can easily work around. And then I go, okay, what have you been doing that you've noticed helped? And then they're like, or maybe not even help, but just what have you been doing? And they go, well, I'm stretching it. And I'm like, I don't think that's what you want to do, but that seems to be everyone's go-to is like, if something hurts, stretch it or massage it, which would be even more specific to you guys, which I don't really have a question about that. Just kind of an observation where it's like stretching is just a go-to for so many things when I don't like in many situations and maybe even the majority, it's actually going to hurt more than help,
Yeah, probably. It's a very, very much a thought that people have had for a long time, that stretching is kind of the be all end all, right? It's as far as injury reduction, things like that. But I mean, using your example of a strain there, if you think about when do muscles become strained, when they're kind of at the physiological limit of stress, right? So no one, tears their hamstring bending over to tie their shoe, right? You do it sprinting, right? So that's a load tolerance issue. It has nothing to do with necessarily the range of motion.
Right. Yeah, which is interesting because then they would try and address the range of motion by stretching, right? Be like, oh, I'm not flexible enough. That's why I got hurt.
It's silly to someone like yourself who kind of understands it. But I think you can create some buy-in as far as injury reduction and strength training goes. Strength training seems to be the number one thing we could do for things like that, right?
Right. Yeah.
Yeah. Well, here lies the problem. Here's when someone has a issue, let's say what's the word they use? They go, I feel tight. Because again, if there's an injury, your body will tighten things up so you don't move to not injure yourself further. Very simply put, right? So you feel tight. So the knee-jerk response would be like, oh, stretch it. You won't feel as tight. You won't feel as much pain. So I completely understand when people go, yeah, I want to stretch it. Can you show me a stretch? And I go, yeah, of course. But like, I don't think this is necessary right now. I think this is actually more efficient, meaning like we'll get you better faster if we do it this way. What do you think? And I think that's very important to ask someone do they think that's going to be okay?
For sure.
Right. But it's the feeling of like, they feel tight, they should stretch and their pain will go away. So I think that's kind of the problem. So I think you put it well, Matt, that there's some evidence to suggest that stretching could be useful, which Tim and I agree with. I think there's some stretching that can be useful. But do I think everyone should static stretch all day long and it's going to prevent injury? No, of course not. Right. So I think it is very important for people to understand what is actually happening when they're stretching, when to use it, when to not use it, that sort of idea.
I think people also have which was like an important aspect of your stretching series, Matt, is I think people also have a heavily biological based perspective of stretching. Like when they think they're stretching, they look at it purely physiological and physical, just set without the neurobiology in it. Like the brain isn't even a part of it. You know what I mean? And an example I've used, which may be a little bit reductionist, and you could go into the rabbit hole on this, but it's like, it at least helps, I think, illustrate how much the brain plays a part in stretching muscles and tissues and all the tissues around it in general, is if I knock you out, I can make you do the splits.
Totally.
Just that alone is like, oh, okay, yeah. Why can't you do it right now then?
No, absolutely. Yeah. If you look at people under general anesthesia, they have the most range of motion. You could fold them into a pretzel, right? So obviously there's a central governor there, right? And the brain is the king of everything, right? It's overlooking everything. So if you feel that you can't bend forward that way, it's probably very rarely a tissue length discrepancy, right? You're not necessarily, you don't have a true tight hamstring. There's probably some neural governor on that.
If someone is
to work into, but to think stretching is the only way to get rid of tightness is kind of like I said, there's more than one way to skin the cat, right? There's more than one way to make 10.
And maybe a cheaper way.
More
cost-effective way.
Cost-effective, I like, because if you think about, I'm going to spend 10 minutes stretching out my hamstring, or I've seen Tyler talk about using, say, deadlifts or Romania deadlifts for stretching the hamstrings, right? As far as cost-effectiveness goes, it's been shown that eccentric movement can increase sarcomeres, right? Making the tissue not only longer, but then you do have an habituation to that movement, right? Meaning the more you do that RDL pattern, the further forward you will eventually be able to go. And then a lot of people say that tightness is kind of an instability kind of thing. So if you could develop motor control and strength around the hamstrings there, you probably feel a little bit less tight. And a quick example I'd give to people about the fact that you don't have to stretch to reduce tightness is have them put heat on the area. If your neck feels tight, put heat on it. 10 minutes later, I bet you don't feel so tight anymore. Well, you didn't even change the movement of the length of the tissue there. You just applied an extra stimulus, right? That can change the way you feel. So tightness isn't necessarily a muscle shortening thing, right? It's very much a subjective symptom that can be influenced many ways.
I think something to touch on too is, like I mentioned this at the start, was like, okay, we're talking about this from a general population standpoint, not a performance or an athletic standpoint. Because, and that's important, I think, for people to understand, because I had someone a year or two ago respond to a few posts I made about stretching, and it kind of responded in a way that was like, wow, that's bullshit. They didn't really say that, but kind of similar tone. And I don't blame them, because I wasn't acknowledging the performance aspect of it, or maybe even making that clear, because they said, this was their answers. They were like, oh yeah, try and tell that to, after I made a post about a bunch of static stretching stuff, potentially increasing injury in some cases, but in most cases, not doing a whole lot long-term, was they said, oh yeah, try and tell that to all the NHL goalies. And I was like, good point. How many people in the world play in the NHL as a goalie?
Yeah.
Right. And then, but also, it also was a great point, because then I have to acknowledge that, okay, static stretching can work for certain situations, in certain positions. If you need to get into the splits and you're doing the splits all day, you're going to be good at getting into the splits. We already know that. So that's all that's basically saying, right? But a lot of people will say that and use very obscure examples as a way to kind of argue against this. Do you know what I mean?
Yeah.
But yeah, well, but I think sorry, go ahead, Ted.
I was gonna say, that being said, NHL goalies still strain their groin muscles. So, they could static stretch all day long and have the most flexibility in their abductor muscles. Those are the adductor muscles, and they can still get hurt. So things can still happen regardless of if you static stretch every single day or not, which is what I want people to understand. Like, again, stretching can be fine sometimes, but if you think it's going to completely eliminate your injury prevalence, it's not going to.
And why else would you want to do it? I mean, as a gen pop, your needs and goals are usually completely different than a professional athlete or even an amateur athlete. So
definitely,
if you need for some reason to be in a certain position and your tissues need to tolerate that, then you should be exposing yourself to that position regularly. Definitely. That's a given for sure.
Yeah,
but that's not most people.
Yeah. I have a test for everybody right now. Everyone's going to pause this podcast after listening to this. If you feel like everyone that has tight hamstrings, okay? If you have someone around you, that'd be perfect. You guys should both try to bend over and touch your toes. And you're going to measure if you can't touch the ground, obviously, measure how far away from the ground you are. Okay. And then you're going to scratch each other's head, the back of your head or top of your head or whatever, for 30 seconds, or scratch yourself if you're by yourself, or if you're in quarantine by yourself. scratch your head as aggressively as you can, scratch the back of your head for 30 seconds, then try to bend over, touch your toes again. That's it. See how and I'm curious to see how you feel. That's it. That's all I want to say. Pause the podcast, do it right now. And then you can come back and listen. I almost guaranteed you got closer to the ground, right? And you didn't do anything to your hamstrings. You rubbed the back of your head. So alluding to Matt's point before, you put heat on something, you're probably not going to feel tight anymore, right? And then you put it perfectly, Matt. Thank you. You took the words quite literally out of my mouth. If you have tight hamstrings, go do some RDLs and deadlifts. Unless the hamstring, it was a hamstring injury. If you strained it, might not be the best idea right now. Let's take it easy. Let's just rest until the tissue recovers, until the muscles actually heal themselves. And then we can get into RDLs and deadlifts and stuff like that. So,
yeah. And I think especially with patients, you really have to decipher an objective tightness versus a subjective tightness, because they're two very different things.
Definitely. Yeah. Well, I think everyone comes in. I'm sure you hear this, Matt. When's the last time a patient came in and didn't say they felt tight somewhere?
I want to claw my eyes out when I hear tight.
Yeah, dude. I know.
I'll typically ask them for another descriptor.
Oh yeah.
Well, to me, I think a lot of the time what they mean is a very low level pain.
Right.
It's so low level they don't want to call it pain though.
Right.
Definitely. Yeah. Well,
That's
whenever someone
point.
says they feel tight, I go, cool, where do you feel tight? And they point to a muscle group or whatever it is. And then I'll bring them through range of motion testing. I want to see if it actually tight in the classical sense of you can't lengthen the muscle.
So there it is, the objective versus subjective, right? I think
exactly,
it's just some sort of, afferent information that they're getting that they're interpreting as tightness, right? But that tightness is always kind of occurring in a muscle that is in its mid-elastic range, right? It's not, if they kind of say, oh, when I start to move, I can't move as far, or I can really feel the tension starting to creep up when I start to get to end range, then it may be a little bit more of an objective measure. But, that subjective piece, tightness kind of infers that it needs to be lengthened, right? So you want to go back to us talking about words, and the words we use matter. Tightness kind of infers that something needs to be lengthened of some sort, right? Whereas the subjective piece, if you can use something other than tightness, you'd probably get a better understanding of what's actually going on.
Definitely. Well, I usually ask people, so I tried really hard over the years when someone says tight, instead of going, we'll see about that. I just go, oh, okay. Cool. I bet it feels tight. And then we go through the objective, testing. And if the objective testing doesn't show any signs like that tissue is kind of injured and it can go to the length of range of motion that I'd expect it anyways, I'll go, oh, cool. Like, do you only feel tight right at the end? I'm like, well, that's as much range of motion as I would expect it out of you. That's awesome. So I just reassure them that look at I see people all day long, and that's as far as I'd want you to go. That's awesome. And because you can go this far, it kind of means you probably don't have an injury. That's fantastic. So I acknowledge that they have tightness, and then I go, yeah, but I don't think that tightness is it's not from injury. So that's perfect. And then I go, cool, this is what you can do going forward. And then, and then I'll ask them, well, does it affect you? What part of your day does it affect? Like, what movement does it affect? Like, do you really feel like it affects you doing something? Let's take it neck, for example. If it's like, oh, I can't rotate my head to look at my blind spot. We'll go, okay, that's actually a thing that is really important. So let's work on some neck range of motion. Mm-hmm. So that's where something like stretching, or me doing manual therapy a little bit on, or getting you to move through thoracic spine, because you rotate in your thoracic spine as well. So I'm like, well, can you rotate your shoulders as well? And they go, oh yeah, actually I can look over my shoulder now. So then I go, cool, just try that from now on. Is that all right? Because I just eliminated the only time they feel discomfort is when they look in their blind spot, but moving the shoulders too didn't hurt anymore. Right? Yeah. So that was obviously more efficient than going, cool, I'm going to show you every neck stretch I know.
Yeah.
So I think it's thinking a little bit more critically. And that's pretty much what I get when someone talks to me about stretching. I just want them to think a little bit more critically, rather than dying on the hill of stretching, which is fine, I guess. I don't know. And everyone's still going to say, even after this 15 minutes of conversation about stretching, people are still going to go, Tim and Tyler hate stretching, and they're stupid. So it doesn't really matter at this point.
The former is correct. The latter, no, the former is false. The latter is correct. We are so stupid. But yeah, we hate stretching, but we're stupid. We're absolutely stupid.
Yeah. Anything else you want to ask there, Timmy?
No, I think I extinguished all of my questions for Matthew.
Sweet. Matt, do you have anything else you wanted to say, or like any questions you want to go over?
Oh no, I feel very ill prepared now though.
Oh man,
no,
this is
nothing in particular.
Right. This is our job to ask questions. It's okay.
All I'm going to say is next time, maybe in October when this quarantine's lifted, we're going to get together in person so I could come lift at Modus.
Yeah,
absolutely.
Yeah,
that'd be great.
Definitely.
Matt, it's that time of the show, and if you don't know what time it is, then you don't listen to the podcast. I'm not going to call you a liar. If there's one thing you could, oh my God, you would have thought I've done this before. If there's one thing you'd want everybody on this planet to know, what would it be?
Oh my goodness. Now you're going to call me out.
Yeah. Dude, they can literally be anything.
Let's kind of keep up with the current times and practice physical distancing, because it does make a difference. So I want everyone on this planet to know that, so we can kind of, I'd like to go back to work. I'd like to go outside. I'd like to go to the gym. So if everyone can stay home and get me back to that'd be great.
Agreed.
Fantastic. Stay inside, folks. Like we are. That's why we're bringing you Zoom podcasts. Stay inside and binge listen the podcast. Okay.
That's it.
That's awesome, Matt. Thank you for promoting me and Tim. That's fantastic.
Oh, thanks for having me on, guys.
Well, dude,
no worries, man.
Can't thank you enough for coming on. This was fantastic. You sound 10 times smarter than I do, so I think you should be the host, and you should host with Tim. And you guys can just have me on at some point.
There we go. Ty, do you want to be a guest on our podcast?
Absolutely, please. Stay tuned. Episode 49 is the guest is Tyler Patterson. Fantastic.
Yeah.
All right, Matt,
that's gonna be good.
Let everyone know where they can find you. Obviously, we'll put all of your social media and that sort of thing in the show notes, but let everyone know how they can get a hold of you and that sort of thing.
I'm really only active on Instagram for the most part, and I need to double check, but I think my handle is Matt Angell RMT, with 2 L's, not to be confused. Yeah.
Fantastic.
And that's really the only place I'm super active as far as posting content and stuff like that.
Sweet. And you work in Guelph and Cambridge, right?
I'm at Aramosa Physiotherapy in Guelph, and I'm at Grand River Sports Medicine in Cambridge.
Fantastic. Obviously, when those open at some point, hopefully in the near future, please go see Matt if you're in and around the area. Highly recommend him. And if you don't already know from this podcast, he's super, super smart. So highly recommended. He'll teach you all things CrossFit too, because he's one of those people. All right, guys. Thanks for listening again, everybody. And we'll see you on the next one.
See ya.